We are going to have an interactive session. We've had months of lectures on various topics, but now I think it's time to try to put some things together in terms of what we've learned. And if we need to start doing some lectures on various topics again, we will. I'd appreciate it if everybody could turn their camera on and turn their microphone on, because I'm going to start asking you guys all some questions as we proceed. What I've got here is a series of cases, all with different pathologies, and I'd like to go through these cases one by one and talk about the challenges not only in diagnostics but treatment, and let's just see how this goes for everybody. So again, turn your cameras off. Turn your cameras on, unmute everybody so that I can hear you, and try to keep the background noise as low as possible, okay? So let's start with case one, all right? Case one is and if you know these patients, because some of you might know these patients, you can reserve any comment. So case one is an 18-year-old male. He's Somali Ethiopian. He currently lives in Somaliland, and he's had a history of chronic otitis media since age 1. So for 17 years, he's had chronic otitis media. He's had hearing loss on both sides, progressive hearing loss, and his hearing is better on the left side. Drainage is on and off. He's got no vertigo, and he's never seen an ENT before. So let's look at his audiogram, and we've got his otoscopy. So audiogram, we're going to ask Jose Lovera from Asunción, Paraguay. Jose, could you do us a favor and just unmute your microphone and tell us exactly what you see on otoscopy of the right and left ear, and also what the audiogram shows. We have to wait for Lovera to give us a response here. Okay, Lovera, you're not with us. Okay, Oscar, you're there. Oscar, go and if you could tell us what the audiogram shows on the right and left side, and also if you could tell us what the otoscopy shows.
Hello, everybody. So the audiogram is definitely showing a significant mixed hearing loss with both active and sensory neural hearing loss on both sides. The worst ear is the right side, and on otoscopy, there's a lot of inflammation in the external ear canal. There's no much landmarks to identify any structures, and there's a lot of purulent discharge on both sides, and maybe there is some granulation tissue, especially on the right side, and the left side is a lot of pus. And as if I understand the left side correct, it looks like a total perforation, very sick.
This is the right side. This is the right ear, okay? Tell us what you see on otoscopy on the right ear.
Oh, okay. So this almost like total perforation, the shorten of the handle of the malleus, and very thick mucosa in the middle ear. I cannot see any round window. I'm not able to see the oval window or any structures, stapes or inclusions.
Do you believe the audiogram? Because the audiogram showing at least a 40 decibel hearing loss. Is that consistent with what you're seeing here? A total perforation and questionable ossicular chain? Is this consistent?
I think that it should be masking done because it can be almost completely deaf ear and
No, the answer is you're at
the mask.
anytime you got more than 25 decibel hearing loss, and this is far exceeding it, you have ossicular chain erosion. The maximum loss you're going to get is about 50 to 55 decibels. So this is consistent with a total perforation and what appears to be just a remnant of the malleus right here. Okay, let's go to the other ear. This is the patient's better hearing ear. Okay, obviously the audiogram confirms the patient's symptoms, where the patient says, I can hear better on this side. So what is all this stuff? Tell me what you're seeing. Tell me what you see here. Okay.
So it looks like purulent discharge. It can also be the matrix of the cholesteatoma on this side.
Okay, I don't see purulent discharge, but I see cholesteatoma. Okay, and then what is this structure here?
It looks like the handle of the if this is the left side, it should be the handle of the menu, and this handle is definitely medialized. And
Okay, so we have the remnant of the malleus. We don't see any of the other ossicles. Okay, so we've done the diagnosis on the right side, diagnosis on the left side. What other tests do you want? What other tests do you want now?
I think that the CT scan is a good option, especially if we're considering performing the operation.
Okay, so you want to see
the surgeon is not very.
All right, so we're going to look at a CT scan here. And we're going to go down lower. All righty, so we're looking at the CT scan. What are you looking on the CT scan? What do you want to see?
Maybe some vital structures, and before planning the operation, it's nice to look at the position of the facial nerve, and if the facial nerve might be dehiscent or any problem with the facial nerve. Also, semicircular canals, and the how low is tegmen, what's the type of the
Okay, let's look at
central
the
bone
coronal
is
CT.
sclerotic.
Here's the coronal CT. I like to go from posterior to anterior to posterior. So we're going through the sphenoid sinus now, and we're going further backwards. Okay, and we're going to go to the petrous apex right here. This is the petrous apex. Oops, sorry. This thing's a little crazy. So we're going to go to the petrous apex. This is the coronal. We want axis. Son of a gun. Okay, so we're going to look here at the petrous apex. And this is the petrous apex. We talked about this. We had a lecture before on petrous apex. All right. So here we are at the petrous apex. Okay, here's the clivus. Here's the petrous apex, the carotid artery. And we can see the pneumatized portion of the apex right there. So we're going from anterior to posterior. So let's go. Now we're going to get into the cochlea. Here's the cochlea. We can see the malleus. We can see some opacification here. We can see some little erosion of the scutum on this image. And then we're going to go up a little farther. Okay. And what we've got here is another image. Okay, we're picking up our horizontal canal. So we've got a total perforation with cholesteatoma. We're seeing some opacification up here. Mm-hmm. We see some opacification up in the attic and the mastoid. Okay, and that's about all we're going to get off of this. We don't see any defect in the tegmen here. Okay, and we don't have any horizontal canal fistulas. Everything, for all intents and purposes, looks fine. So now let's go to the axial CT. And we're going to start from superior, because here we have our superior canal. Sorry. We've got our carotid. We're going to start coming into the apex of the cochlea. Hold on a minute. Here's the apex of the cochlea. Internal auditory canal, part of the vestibule, malleus, incus, middle ear, addison, and antrum, and then the mastoid air cells will start to be right about there. So we're going to go down a little lower. Here's our basal turn of the cochlea, the round window. And if we look on the left side, which is the side that's got they both have perforations, remember, we look at the left side, we see opacification, we see a little air in here. Okay, so we've got, for all intents and purposes, a nice cholesteatoma. Okay, we don't see any complications other than a conductive hearing loss. All right, so based on the hearing and the CT, which ear are you going to operate on? Oscar, which ear do you operate on?
I will operate the worst ear first.
The worst ear.
According to the audiogram, and maybe if the ear.
Okay, which ear are you going to operate on, the right ear or the left ear? Here's the audiogram again. Which ear are you going to operate on?
I think the right ear is.
No, I don't want to. I want to know. You're in surgery. You've talked to the patient preoperatively. Which ear are you going to operate on? Agata, which ear are you going to operate on?
With right ear.
Agata, which ear are you going to operate on?
Left ear.
You're going to operate on the left ear, and Agata,
Left.
you're going to operate on the left. Okay, so let's get Artem. Artem, if you're there, tell me something. Which ear are you going to operate on?
Yeah, I'm here. I'm going to operate left ear.
Artem, which ear are you going to operate on, the right ear or the left ear?
Do you hear me?
Yeah, we hear you, Artem.
Do you hear me?
Yes.
Left ear.
You're going to operate on the left ear. Okay. This is definitely a challenge. Jose Lovera, if you're there, I'm asking you, which ear are you going to operate on?
Hi, Richard. May I see the CT scan first? Again, please.
Yeah, which axial or coronal?
Just a little bit on this. What?
Axial or coronal CT?
Axial.
Okay, hold on. Okay, so here's our axial. You see it okay?
Yeah, I'm seeing.
So it shows opacification in the epitympanum. There's no erosion of the tegumen. There's no lateral canal fistula. It's just basically epitympanic disease and mesotympanum. Okay, so the question is here, which ear are we going to operate?
Oh man, you see worse the left side.
The left side has a cholesteatoma.
The audiogram tells us that the right side is worse, and I think I'm going to use diapason first to confirm that audiogram, and then I will decide which one, because the left side looks like worse, but the audiogram in the right is worse. I will think I will use the diapason to confirm it.
Okay, here's the situation. This is a difficult case. Okay, and here's the situation. I would probably operate on the left ear for the following reason. We have a cholesteatoma here. This patient can live with a perforation. Cholesteatoma is going to get larger. It's got potential to create complications. even though this is the better hearing ear. If we're talking about patients who have perforations and pathology that cannot cause significant complications, we need to take care of those. So let's say we operate on this patient. We got about 60% chance of the hearing state staying the same or getting worse. But let's just say that we operate on the patient and they lose their hearing. They go deaf in this ear. If they go deaf in this ear from surgery, and it's 1% patients who have ear surgery go deaf, we've still got this ear. We've got a large conductive hearing loss. It's a safe ear. It's relatively dry. And we could put a BAHA on this patient. We can put a bone anchored hearing aid and keep this patient functional. Okay. Let's say we operate on this ear first, the right ear. And let's say this ear goes dead. If this ear goes dead, we still have to operate on this ear. Okay, because we've got a cholesteatoma. And because we have a cholesteatoma, the question is, we got a dead right ear. Now we're operating on this ear. We got 60% chance we're not going to make anything better. Okay. And we got about 30% chance we can make things, or not make things better. And 60% keeping them the same or getting worse. So it's a challenging case, but the most important thing is, at least from my perspective, is you've got to get rid of this cholesteatoma. Okay. This ear is safe and we can put a BAHA on it. Okay. So we operate, let's say, what kind of surgery? This is a total perforation, ossicular chain erosion, cholesteatoma. What kind of surgery are you going to do? Are you going to do tympanoplasty? You're going to do a canal wall up mastoid, or you're going to do a modified radical?
I think that we should try
I didn't hear you. I'm sorry. Your connection's a little weak.
Cholesteatoma we can remove. Then, sorry. Now I will find. Now, do you hear me?
Yeah, it's better. Thank you, Agata.
I would try to make mastoidectomy canal wall up, and because when we see that all cholesteatoma we can remove, then I would try to, because it's Ethiopia and we really we can have an opportunity to make 1 year after operation. So we should try to, first we have to see what is with stapes. If stapes it is flexible, or it's the plate of stapes, it is flexible. Then we have or PORP when the stape is still on its place, or when there is no stape, the TORP. And when we have a TORP, then we have to have then we have to cartilage on the TORP, and then the new tympanic membrane.
Okay, so it sounds like you want to do this. You want to do a simple mastoidectomy first, identify the extent of the disease, and if you can leave the canal wall up and do a tympanomastoidectomy, that would be great, with an ossicular chain reconstruction using a TORP or a PORP with cartilage over that. I totally agree with you. Should we need to take the canal wall down, we can do a modified radical or a radical, depending upon what's left in the ossicular chain and how much middle ear space we can maintain. So Agata, one other question. Because you've got a cholesteatoma here, if you read the textbooks, what does it say is a structure that is very, very much at risk of having potential damage because of a cholesteatoma that can cause patients to be dizzy?
The incus.
No,
Ah,
no.
the dizzy, the cholesteatoma first. I thought that you are asking what's the structure of ossicles cholesteatoma destroy first. So it is the incus.
That is
But
correct.
for a dizzy inpatient, yes, there could be probably dehiscence in the semicircular lateral canal.
Exactly. The
So in
lateral.
this place, we should be very, very careful. And during removing the cholesteatoma, we stay at the step where we just lose the cholesteatoma on the stapes and on the region of semicircular canal. Then we have to find other places where the cholesteatoma is, and at the end of our removing the cholesteatoma, we should be prepared that could be the dehiscence of this canal. So we should be prepared for it, and have a graft or the glue or pate. We should be prepared that there could be dehiscence.
Exactly. We have to be prepared for lateral canal dehiscence in a case like this. Exactly. And when you have a lateral canal dehiscence, okay, what other structures are at risk? What other structure is next to the lateral canal that can give you the potential for another complication other than dizziness? Agata, you're almost done. So there's a structure just next to the lateral semicircular canal that controls facial movement that we need to be very careful about. Agata, you with me?
Yes, I'm thinking. Yes,
Okay.
yes.
It's not a hard one, Agata. The structure just below the
It's not a
horizontal.
hard.
No. It moves the face, Agata.
No, stapes. Stapes.
The stapes doesn't move the face. The facial nerve.
Ah, the face. I thought that for a dizzy. So I thought that you asking for the next structure which makes a dizzy. I thought between, yes, face, of course, facial nerve.
Okay. Okay. Just one second. Okay. So the thing is this, the facial nerve is always at risk, okay, when you have potential erosion in the lateral semicircular canal. Okay. All right, let's talk about case number 2. These are very much real cases. Aziz, if you're there, Aziz is, this happens to be a case of Aziz.
Yes. Yes. I'm there.
How you doing, Aziz? Tell us, Aziz.
I'm here. Yeah.
Have you operated on this patient yet? Aziz,
Yeah. I have operated this case today, and I've stayed with the pro.
you operated already?
Can you hear me?
Yeah, we hear you. It's a little weak. Tell us about what you've done with this patient so far.
I've operated him today, and I have started with the right ear.
You started with the right ear.
Which was the worst, with the right ear with the worst hearing.
Mm-hmm.
And that's I have done. I have explored the middle ear cavity.
And were the incus and the stapes
there
gone?
was adhesions all around, and the ossicles, the mali. There was no incus. There was no incus. The stapes was there, but a lot of adhesions over there. Adhesions, mucoid glue-like discharge coming from the attic. I have sucked it, and I have removed the only ossicle that was present, and I could identify. Can you hear
Izzy, we got a little, it's a little slow today for you.
No problem.
Aziz, shut your camera off. Shut your camera off.
Can you hear me?
Yeah, shut your camera off, possibly.
Can you hear me?
Shut your camera off.
What?
Turn your camera off.
Okay.
And maybe we'll get a little better voice from you. Okay, Aziz, can you hear us now?
Okay, I'll shut my camera off. Okay.
Okay.
Yeah, I can hear you clearly.
Okay, it's much better. So basically you went in there was a lot of granulation tissue. There was no incus. Was there stapes?
Yes.
The stapes was there.
There was no incus. There was stapes was there, but it was almost fixed with adhesion. There's a lot of adhesion is around the stapes.
What did you do in terms of reconstruction?
But no cholesteatoma was there.
Okay, did you do any reconstruction?
I have the only ossicle that I could get was the malleus. Yes, I have the malleus head. I got reconstruction, and I have get a malleus head. So I have put a little bore hole, and then put on in front just the stapes head, and then put a cartilage, and then made a tympanoplasty.
Okay, the other thing you could have done was
that was only.
You took the head of the malleus and used it as a port. You could have also taken cortical bone and used cortical bone and fashioned a port to put over the head of the stapes as well. Okay. All right. Why did you use cartilage on the head of the port?
But I could. Because of just to support and then to reconstruct the attic because of I have removed some of the attic.
Okay, so you used it to.
I have used it to support the bulb as well as to reconstruct the attic because of I have removed some of the attic and so.
To prevent a retraction pocket in the future. Okay, it makes sense. Okay, all right, sounds good. Okay, we're going to talk about case number 2. All right. Case number 2 is a 52-year-old male. He lives in La Paz, Bolivia, 14,000 feet high. It's the highest city in the world where people, well, there might be some other ones in Nepal, but at least for South America, it's 14,000 feet. He complained of hearing loss in his both ears. His right ear was greater than the left ear. Okay, excuse me, his left ear was greater than the right ear. No vertigo, no tinnitus, no drainage. And here we have his otoscopy, okay? So I'm gonna ask, Nega, are you there? Nega, I think Nega departed. Okay, so let's see if we can, Asuk, before you go to bed tonight, could you answer a few questions for us? Tell us what the diagnosis is of the right and the left ear. Hold on a minute. Asuk.
Hello.
Yeah, hi, Asuk. Asuk, could you tell us here what the diagnosis is of the right ear? This ear, right here. Tell us what you see going on.
There is a gross retraction is there.
Okay, so there's a retraction right here. Okay.
For the, from anterior also there is a retraction, and anterior half and posterior half also. The majority of time this perforation is also seems to be retraction unless and until we go for endoscopy or microscopy.
Okay.
This
So
appears to be.
Go ahead.
And there is a dimpling at this side that just above this head of malleus. Yes, there is a dimpling, and IS joint is clearly seen, but there is a little bit this stapes and this incus. There seems to be thinning of the long process of incus. That one.
Exactly. We've got a small retraction pocket here. It looks clean. We've got a
Yeah.
large retraction pocket, normal
Yeah.
drum posterior. We've got incus, head of stapes, stapedius tendon, and we have a little bar
little
of.
bit. There is some problem. There is thinning of that problem. There is a thinning.
Okay, so this is called a maryngostapediopexy. Okay.
Yeah.
This is called a maryngostapediopexy because the drum is on the head of the stapes. Okay.
Directly in
Okay.
touch.
Now, Asuk, since you're here, tell us about the left ear. What do you see on the left ear?
It seems to be a large perforation.
Exactly. It's a total perforation.
Total perforation. And this part is supposed seems to be either cholesteatoma or tympanosclerotic patch. This one. That one.
Okay, that happens to be cholesteatoma. Okay.
Cholesteatoma.
Exactly. So it's cholesteatoma. All right.
Cholesteatoma. Yeah.
So we've got a patient who's got two really bad ears. He's got a cholesteatoma here with a total perforation and residual malleus. We've got an attic retraction, tympanic membrane retraction, and a maryngostapediopexy. So those are our two diagnoses. Okay, what kind of test do you want to do now? So we've seen these patients, we've listened to their history. What's the next thing you want to do?
We will go for this audiogram for recording purposes, for pre-op and post-op to compare, and for the medical legal purpose also.
Okay,
so we will keep the audiogram with us.
Okay.
And being on left side, there is a cholesteatoma. We have to go straight forward to make this ear shape.
Okay, let me ask you.
We should operate on this left.
Here we
left
have.
Side. We have to operate.
Okay.
Yes, please.
Before we get to that level, Asuk, let me ask you a question. Here is the audiogram. It shows a large conductive hearing loss, 40 to 45 decibel conductive loss on both sides. Okay.
Yeah.
Do you think this audiogram is correct? I mean, we have two different pathologies here. We have a large perforation, cholesteatoma. We don't see any ossicles other than the malleus. Here we see all the ossicles. We got a retraction pocket with a maryngostapediopexy. Would you think that both of these pathologies are going to cause the same hearing loss? Or do you think this might be worse than this?
It may be worse on right, but as far as I am concerned, wherever there is I will suspect cholesteatoma. Even if there is a suspicion, I will first go for removal of cholesteatoma and making the ear safe.
Okay, we know we got a cholesteatoma, but that's not the question. So listen to the question.
Yeah.
Do you believe this audiogram to be correct? Do you believe that the audiologist did a good job in testing the patient?
Audiogram correct because of cholesteatoma hearance we may get hearing better on this side, left side.
So you think the hearing should be better here or here?
It should be better on this side. Left side.
What's this side, right or left?
Left.
So you think
on
the
right
left
side
should be better than the right? Okay,
right side there conduction will be a problem. Right side conduction will not be complete, or it will be a problem on the right side.
Okay, let me ask you another question.
Yeah.
Do you think this is correct, the audiogram? Yes or no? Just give me a yes or no answer.
No.
Okay, so you don't believe this is correct. That's right, because it's not correct.
Yeah.
And let's think about this, because this is very important. Here we have a maryngostapediopexy. We got some erosion of the incudostapedial joint, but there still is some connection. We have a conductive hearing loss.
Yeah.
We have a 25 decibel hearing loss. Okay. And that's what we're going to expect here. Here, we don't see the incus or the malleus. Okay? We do not see incus or malleus. We're going to have a larger conductive loss here because we got a total perforation and no ossicles. So you can see here that the conductive loss is much larger. That's why this is wrong. This is showing both ears to have the same hearing loss. And it's impossible. I shouldn't say it's impossible, but it's very unlikely to have the same hearing loss on the right and left side, when in this case, on the left side, we have no ossicles. And here we have an intact ossicular chain with some loss of hearing at the inculastopidial joint, but it shouldn't be as bad as this. Okay, so let's talk about our treatments now. Okay. All right, Damien, are you there? If you are, take your microphone and talk to me.
Yes, I'm here.
Okay, hi, Damien. So Damien, help us out with this last part. Okay, here's our right ear, and Asuk was very, very good at telling us we have a retraction here. Let me ask you a question. If this patient tells you that they cannot hear on the right side here, they're telling you, hey, Dr. Damien, I can't hear on my right ear. Okay, what do you do? What are you going to tell them their options are if they can't hear?
Cannot hear, right?
Well, they could get tympanoplasty with a PORP.
They could get a tympanoplasty with PORP. Okay, would you put cartilage on there? On top of the PORP, are you going to put cartilage? Yes or no, Damien?
I didn't hear. Repeat. The connection went bad.
Okay, if you're going to put a PORP on this patient and you're going to do surgery, are you going to put cartilage on top of your PORP?
Yes, I would.
You need to use cartilage. In cases like this, where they have dysfunctional eustachian tube, which is the cause for the retraction, you need to put cartilage on top of your PORP. Otherwise, the pathology will return. Why will it return? They don't have a functional eustachian tube. Middle ear pressures are negative. You need the support of cartilage to prevent this from retracting again. So Damien's going to do a cartilage tympanoplasty with PORP, okay, because we have a stapes superstructure, okay, and he's going to do the surgery to improve the hearing. One of the things you can do for your PORP is you can take the incus out. You can put the incus and drill it and fashion the incus to make your PORP. And that PORP will sit right on top of the stapes head, some cartilage to cover the whole area here, and then you put your graft on top of that. Okay, so that's if the patient can't hear. Is there anything else you could do, Damien, if this patient wanted to hear, but they didn't want surgery? So they're telling you, Dr. Damien, I don't want surgery. I can't hear. Are there any other options? And are there any other options, Damien?
Yes, they could get like a hearing aid, I would assume.
Absolutely. They could get a hearing aid or a bone anchored hearing aid.
Okay.
And they'll function fairly well. Okay. So surgery is an option. However, there are two other options. Okay. Let me ask you another question. Let's say they can hear perfectly well on this ear. Are you going to do anything? Are you going to operate or leave it alone? Which one? Damien?
Well,
Is this ear safe?
I'm assuming that the pathologist.
Damien?
No.
Is the ear a safe ear or is it a safe ear? That's my question.
I would say no.
It's not a safe ear. Do you see any kind of pathology here like cholesteatoma formation? This gentleman's had the same eardrum for 20 years.
Well, no, there's no obvious cholesteatoma.
There's no cholesteatoma, correct? So my question for you is, if there's no cholesteatoma and the patient's got a dry ear and they've had this for 20 years, is there anything you need to do?
I would say no.
That's correct. You don't need to do a thing to this ear. It's a safe ear, it's a dry ear, and the patient's telling you, I hear okay. Okay, you see him back in a year and you re-examine him and you'll see that nothing has changed in this patient. All right, let's talk about this ear. All right, let's talk about the left ear. Okay, so Daniel Vasquez just joined us and he's eager to help us in talking about the pathology here. Daniel, can you turn your microphone on, please? Let's see if Daniel responds. We're going to look at the left ear here. Daniel's not. Milton, if you're here, could you help us answer some questions? Okay, everybody's sleeping. All right, very good. Asuk, let's talk about this again. Okay, tell me about this left ear. Okay, this left ear has a total perforation, a small cholesteatoma. Okay, what are we going to do with this patient's ear? Okay.
Should I answer?
Asuk, what are we going to do here? If the patient cannot hear on the left side, what is your plan? What kind of surgery would you offer this patient?
First, we have to go for this removal of cholesteatoma inside out.
Okay, so you're going to do an inside-out approach. Okay, that's a reasonable approach. When we talked a long time ago about doing surgery, we talked about inside-out approach. And just to refresh your memory, that's where we start drilling. Okay, that's where we start drilling in the ear canal. Okay, and we start to stay at the level of the tegment and go posteriorly, being careful to watch deep to our drill because we will have the facial nerve and the horizontal canal. Okay, so inside out, and hopefully by doing an inside out, we can limit the size of the cavity, preserve the posterior canal wall, do an ossicular reconstruction with either a PORP or a TORP, and
here
do a lateral.
we can stage the operation.
I'm sorry?
We can stage the operation. We can stage the operation.
You can stage it, but I would do it in one stage. Okay, that's just me. Okay, but yes, we could stage this operation. Okay,
We can go for.
Go ahead, Asuk. I'm sorry. Okay, let's look at just a couple of these other cases, and let's just talk about them. Agata, this case right here. Tell me what you see, and would you tell this patient they need surgery or not? And let me help you through this. What structure is this?
Malleus.
Okay, good. What is this structure?
The stapes, but the
It's
process of head of stapes.
It's the head of the stapes, and I'll help you. Here's the stapedius tendon going to the pyramidal eminence. Okay.
Yes.
Now, do you see an incus here?
No.
No incus, exactly. And what is this structure right here?
Facial nerve.
That's the facial nerve. Perfect. So we got a large retraction pocket. We have exposed facial nerve. We have stapes. We have promontory. We have malleus. We have no incus. Okay. Look right here. See this little edge right here?
Yes.
It doesn't look really healthy. It looks like a shark took a big bite. Okay, so it's got an irregular edge to it. Okay, really irregular. Whereas this edge right here is nice and smooth. You see that?
Yes.
This edge is smooth. This is smooth. But when you start getting here, you can tell we've lost bone here, and we've got an irregular edge. That's telling me that there's something a little more going on than just a retraction pocket. Okay, so it'd be really probably helpful here. It'd be really helpful to put an endoscope in there and see if you see any cholesteatoma behind here. All right. So let's say we don't see any cholesteatoma, but the patient is told to come back in 6 or 9 months, and the patient comes back. They lived in Warsaw, but they came all the way to see you because they know you're a good doctor and you don't lie to them. Okay. And the patient comes back in 6 to 9 months, and you tell the patient, boy, it looks worse than it did before. Okay. All right. Hold on a second, guys. So you look here, it's worse, and you see a little cholesteatoma. What do you tell the patient now?
Now we have to make operation, but first we have to make a CT scan.
Okay, so you can do.
I ask also of vertigo, and make audiogram. We don't see. We don't have an audiogram.
Okay, so we do an audiogram. We've got that. We do a CT scan. It's not a big. It's a very small cholesteatoma. So, what kind of surgery are you going to do here? Okay, I got it. What kind of surgery are you going to do? Are you going to do a? I'll give you the options. Okay, so you could do a tympanoplasty with cartilage, with a PORP, and a small adicotomy. Okay, or you could do a tympanomastoidectomy. So which of those options would you prefer to do?
First, the first option.
The
because
first option. Okay, the
yes,
first option is the right option. Okay, and the reason why is because you don't have to drill much here. You have to make this ear safe now. And because of this active erosion of the bone, okay, I got it. Because of the active erosion of the bone, and because you cleaned out a small cholesteatoma, you're going to drill this down a little. You're going to reconstruct the tympanic membrane with fascia, and you're going to put a big piece of cartilage here with a TORP, with a PORP. You might not need to put a PORP on. You might be able to just lay the cartilage right on the head of the stapes and get a conduction that way. If not, you can take a little cortical bone and put the cortical bone, drill it, put it on top of the head of the stapes, and then you'll put your cartilage here, followed by your fascia. Okay? So that would be that. Okay. Who's next here? Milton, are you there? Milton Fili, are you there from Ethiopia? I'd ask Izzy, but Izzy's not, he's going to start his residency.
Hello?
Yeah, Fili.
Yeah, hello, Richard. Yeah, I'm here.
Browner. Fili's name is Browner. Fili, thank you for joining us. Listen, you see this ear here? Right here?
Yes, yes.
Okay. Describe to me, okay, let me help you. What is this structure, Fili?
It's malleus.
Excellent. Okay, and this right here?
Incus.
Okay, and this here?
Steps head.
That's the set of stapes. This right here?
Steps tendon.
Exactly. And here's pyramidal eminence. Okay, so we've got a really intact ossicular chain here. What is this structure right here?
Promontory.
Absolutely. Now just use your imagination. It looks like something round here. What would you think that might be?
Round window.
Exactly. So you know what? It's pretty good here. Okay, so now let me ask you a question. Is the eardrum intact or not intact?
It's intact but retracted.
Absolutely. This is a completely atelectatic eardrum. Okay. There's a classification system. We talked about this before in some of the early lectures, okay, about Sadie and TOS. They have these classification systems. Are they important? I guess if you're going to be a professor and you want to teach, you can talk about them. But the reality is this whole eardrum is retracted. It's sitting on the promontory, sitting on the ossicles. It even has some tympanosclerosis in the drum or laryngosclerosis. Okay. So Philly, this patient comes from Gondar. Okay. They come from Gondar all the way to Mekelle to see you. Okay. Because they've heard that you're a really good doctor in Northern Ethiopia. And the patient says, I can't hear, doctor. What do you tell them their options are, Philly?
So their options are one, we can do tympanoplasty. And
Okay.
another option is if they don't want surgery, we can do hearing aid.
Absolutely. We can do a bone anchored hearing aid. We can do a regular hearing aid. Okay, let's say that you don't have a lot of, well, let's say this. Hold on a minute, helicopter going by. Just a second. So let's say you've got a lot of experience in surgery, okay? And you and you see this patient, what kind of when you say you're going to do a tympanoplasty, tell me what you're going to do, how you're going to reconstruct the ear, and with what materials.
So we need fascia graft, but we have to put cartilage above the stapes head.
Okay,
So that it will
absolutely.
prevent retraction.
Absolutely. You need to put cartilage on top of the head of the stapes to get the conduction going again. And this is not unlike the other reconstruction. We're going to put cartilage, but between the cartilage and the head of the stapes, we might need a PORP or we might not. And if we need a PORP, the greatest thing is this. If this is eroded, if the incus is eroded and not giving a lot of connectivity to the head of the stapes, just take the incus out, refashion the incus to be the head of the to put on the head of the stapes. If the ossicular chain is fine, then we'll just put our cartilage around this area and our fascia over it. One of the most important things when you have atelectasia like this is to make sure that when you remove the remnant of the drum, which is paper thin in all these areas, is that you get all the skin out. All the drum needs to come out. You need to get all the remnants, otherwise you'll develop a cholesteatoma. All right? Very, very important. Get all the remnant of the atelectatic drum out. Okay? That's critical. Okay? Let's look at two more of these. Okay. Daniel Velasquez, are you there? Let's see if Daniel finally wakes up. Give him a second. Okay, Daniel, you're not there. Let's see here if, Milton, are you there? We'll go back to Oscar. Oscar, tell us about this patient's ear right here on this otoscopy that we're showing. Tell me what you see and what the pathology is, okay?
This patient have a retraction pockets in the pars flaccida on both sides, and also the tympanic membrane is retracted on both sides, and it looks like the left side might be cholesteatoma, or at least some debris at that retraction pocket area. So,
Okay, so you're seeing some debris here, and you're telling me that's a cholesteatoma.
I'm not sure. Probably maybe not. It depends.
Okay, if it's not a cholesteatoma, what is it then?
It can be the desquamated skin that trapped
Desquamated what?
epithelium that
Desquamated epithelium is a cholesteatoma by definition. Okay, it's not cerumen. A cholesteatoma is desquamated squamous epithelium with bacteria. So this is a cholesteatoma, okay? What are you going to do different with these patients? Are you going to operate on this patient? Tell me what you're going to do in your workup, okay?
So the left side is CT scan is recommended, and then
With the left side, you're going to do a
the left side is CT.
Okay, let's look at this here first. What are you going to do with this patient? What is the next test?
The next test is the audiogram and the tympanogram. It looks like, because the tympanic membrane is a little bit yellow color, maybe there is some
Okay, guys, hold on a second, guys. I gotta get this phone call. Just 1 second. Brian, what the fuck am I gonna do? It's at 60 now. I'm done. Okay, later. Okay, thanks. Bye. I'll call you. Okay, bye. Okay, guys. So here's what we got. What are you gonna do first? Oscar, you're telling me you want to do a CT scan. You want to do an audiogram. We need those possibly, but why don't you stick an endoscope in here and look in the ear and see if you can see the distal portion of this cavity, okay? Tell me if you can see a cholesteatoma. If this is a clean cavity, you probably don't even need to do a CT scan. Do an audiogram. Audiogram's completely normal. You don't see anything on otoscopy, and there's no drainage. I wouldn't do a CT scan. I'd watch the patient. If you have a conductive hearing loss with a clean pocket there, I'd get a hearing test because they should have normal hearing with this pathology. You got to think about everything. You have to think about your CT scan. You have to think about the audiogram. You have to think about the patient's symptoms, and you have to think about what you're seeing. All of this combined will guide you as to your next move, okay? Now, in this case, we got a different story. We got a cholesteatoma. We are going to operate, okay? We're going to get a CT scan, and we're going to do an audiogram. Depending upon the extent of the disease, we will determine how much we need to remove. Most likely, this is a epitympanic retraction with a cholesteatoma that can easily be removed by nothing more than a Bondi technique, or what we call as an adichotomy, repaired by cartilage and fascia graft. Should our CT scan show this to be extensive, and I have seen cholesteatomas like this that go all the way to the mastoid tip, we have a different case here, okay? We have a different situation then, all right? So in this case, I would do nothing more than audiogram, CT, and finally stage my surgery accordingly, okay? All right, so, listen, it's been
as long as you can see the edges of the retraction pocket, and you can see that there is no debris inside, it's safe to watch this ear, even
if you can see
the large retraction pocket. Yes.
Hold on a minute, what happened here? Okay, in this case right here, it's a clean, non-draining. You can see the distal end. The hearing is completely normal. You don't need to do anything. You can see the ink is here through the drum. There's no pathology in the middle ear. This is an isolated pars flaccida retraction pocket. On the other hand, this one is one that's pathologic. All right. We have exceeded an hour now. we've got more cases to discuss, but we're going to save those for another time. And we will, I got some other interesting cases, but again, we don't have time today. Let me ask you guys a question. Was this helpful, or do you prefer to have lectures on a topic? I'd like to have some feedback because
It's extremely helpful.
I'm sorry?
I like this one.
Okay, I got it. You finding this to be helpful?
Yes, yes.
Okay, because it's the process by which we need to think. It's easy
Yes,
to take
you-
something and absorb it. Some people have a
Yes,
lot of
and-
knowledge, but they can't put two and two together. Okay, so Aziz, was this helpful?
Sign the lecture, and sometimes the ground rules would be better.
Wait, I couldn't
But
hear
it's
you.
very
What?
helpful.
All right.
This is very helpful.
Okay, Fili, what about you?
Yeah, it is very helpful. I think we
Don't
should
lie to
have
me.
it. Yeah, it's really helpful.
Okay, okay. Oscar, what about you?
This one is very helpful because we already get some knowledge about different topics, and I think these discussions will help us to put everything together in decision making about the treatment and diagnosis and other
I
options.
mean, this is you've got to put everything together now. If you got to put
Yes.
your radiology lectures, you got to put your surgical technique lectures together. You've got to put your, your otoscopy knowledge together. Okay.
And
You've
we
gotta
have a
put-
practice doctor, practice autosurgery. So you just tell us, no, this time just operate this ear. It's very important for us. Thank you, Richard.
So let's go ahead and, I mean, it's a challenging case, especially that first one of Aziz. Okay. Again, you know what? I would have operated on the cholesteatoma first, even though Aziz did the other ear. It's just, they always say operate on the worst ear first. Okay. Well, if you've got a worse ear and you're going to have to operate on the other ear, it's challenging. It's also based upon your skills and ability. Okay, we might have a lecture. We're scheduled for a lecture on Friday with Dr. Monfred. I'm trying to get him to change the date to another week. I will let you know. I'll send you guys all a message on WhatsApp. The other thing is I would like everybody who's listening, and I'll send this on WhatsApp as well. I'd like you guys to select a case that you have and put the audiometry, the radiology, the otoscopies together. And I'd like everybody to present a case in the next couple of weeks from your own experience, okay? That can help others learn, and you can share your knowledge with us, okay? So I'll be communicating with you guys on WhatsApp. Please feel free to participate in that discussion. And I think we're good for the day. Thank you guys for joining. Any other questions before I sign off?
So you will
Okay, before you sign off, I want to ask you, sorry, Prof. I would like to ask you about what's the best site to harvest the bone? Is it the mastoid or just somewhere else? Or
Wait, what's the best what?
the best site to harvest the
I'm
cortical
sorry,
bone
I
for
can't
osteoplasty?
understand what you're
The
saying.
mastoid or
Aziz, type it in.
the sites of harvesting. Okay, Prof.
Type it
But
in.
I have a
I'll
difficulty
wait
in
for you to
typing.
type. Type it in on chat.
Okay, I'll type it. I'll type it on the WhatsApp group.
Okay, send it in the
type
WhatsApp group and I'll answer
put in
the
the WhatsApp
question that
group.
way. Okay, very good. All right, everybody, listen, until the next
Thank you,
day or
Prof.
so,
Thank you, Prof.
be well, stay safe, and we'll talk to you guys soon, okay? Later.
Thank you, Prof.
Okay, bye now, everybody.
Really appreciate it. Have a good day.